My name is Dr. Neo Mutaung. I'm a third-year registrar in the Department of Anesthesiology at the University of Witwatersrand, currently practicing at Chris Hani Baragwanath Academic Hospital, which is one of the largest hospitals in Southern Hemisphere, and a quaternary level referral center situated in Soweto, Johannesburg. As we are all aware, breast cancer remains the leading cause of cancer-related mortality among women globally. However, beyond survival metrics, we are increasingly confronted with a debilitating sequel of post-mastectomy pain syndrome. In our institution, data revealed a disturbingly high and rising incidence of post-mastectomy pain syndrome within our patient population at Chris Hani Baragwanath Academic Hospital. Upon reviewing the existing literature, we identified a critical void. This gap is precisely what prompted our research. We hypothesized that optimizing perioperative analgesia could attenuate the acute to chronic pain transition. With the guidance of my supervisor, I conducted a prospective observational study at our tertiary institution, enrolling mastectomy patients and randomizing them into two groups. The interventional group received a single short ultrasound-guided erector spinae plane block, or the ESP, while the control group received the current institutional standard of care, which is basically local anesthesia instillation via the surgical drain. These patients were then followed up in the post-operative period. The ESP block consistently provided superior and significantly prolonged analgesia throughout the entire perioperative period. Notably, the ESP group had significantly lower pain scores compared to the local anesthesia instillation via the surgical drain group. Furthermore, the ESP block facilitated a marked reduction in the total perioperative opioid consumption. This opioid-sparing effect directly translated into a reduced incidence of opioid-related adverse events, including post-op nausea and vomiting. Furthermore, it is a fascial plane block, which is technically simple to perform, with an excellent safety profile, circumventing the risk of pleural puncture, pneumothorax, or neurovascular injury associated with more traditional thoracic wall blocks. In contrast, while local anesthetic instillation via the surgical drain technique provides some analgesic benefit, it consistently ranked second in both duration as well as efficacy. Moving forward, our data strongly advocates for adopting the ESP block as the primary opioid-sparing analgesic technique for mastectomy patient. I sincerely hope these findings will serve as a catalyst for robust interdepartmental dialogue and collaborative effort between anesthesiology department as well as the surgical breast oncology department. By integrating this technique into our enhanced recovery after breast surgery pathways, we can preemptively blunt peripheral nociceptive input, mitigating central sensitization, and ultimately reducing the long-term burden of post-mastectomy pain syndrome in our patient population. Thank you for your attention.